Good evening. My name is Jillian Vestal. I am with Panacea Legal. We are going to discuss contract negotiations. We are going to talk through trends that we're seeing in contracts for family medicine physicians, as well as what we're seeing in compensation this year. I really appreciate all of you being with me and spending some time this evening talking through this. Just a couple of housekeeping matters. There will be some quizzes that come up on your screen throughout. So if you have a couple of minutes just to interact with that and provide an answer, we would love to hear from you. And I think get some more information and have kind of a moment for you to interact. And for those of you who can stick with us tonight, at the end of our webinar, you will be given a code to receive a discount for our services. So if you have the time, we would love for you to be able to stay with us for the rest of the night. If you don't, you will receive an email with a recording of our webinar later on, and so you can watch the rest of it at your leisure later. So there will also be some things that come up in the chat. We'll put a link to our website, my email address, things like that. So that is what those are the things to look for tonight. So we will go ahead and get started. Can everyone see my screen? Okay. Um, so we will talk through, like I said, a little bit about contract negotiation. And I think it's important to start with why this matters. So, more than half of physicians in the US report burnout at various points. Okay, here I cannot see my screen. Let me um, see if there's anything here that. Okay, I think now that should be working. Can somebody give me a thumbs up if you can see it? Okay, thank you so much. So we're going to talk through family medicine compensation and contract negotiation trends. So when we're having this conversation, one of the questions we get is, why does this matter, right? Why is this something that we even want to spend time talking about? And certainly when you're signing a document, you want to know what's in it. But beyond that, more than half of US physicians experience burnout at some point in their careers. When they're asked why, they cite things like a lack of autonomy, the expectations put on them by their employers, the burdens and the workload of the administrative and clerical responsibilities. We are not able, of course, to eliminate all of that. But with a good contract review and negotiation, we can eliminate a fair amount of it. We can also be prepared for what we can't eliminate. Meaning, if we can't get rid of it, maybe we can prepare for it. Maybe we can mitigate the effects of it. Maybe we can do things in our own lives to hopefully negate some of the effects of that. So these are things that hopefully will affect your overall well-being down the road and keep you happier in your career longer. So, who is Panacea? Why should you listen to us? We are a law firm that specializes in doctor employment contract review. We offer transparent flat costs. We do all of our servicing in-house. In addition to our legal knowledge, we're also going to bring the market knowledge, meaning we're going to tell you about what we're seeing elsewhere, what we are seeing within your specialty, how your contract compares. And we also offer 1 year follow-up. So we're not just going to review your contract and then sort of send you out. We're going to review your contract, and then you can come back to us with any other questions. If you get a new draft, if they respond to an email and you're not entirely sure what it means, you can bring that back to us and talk through it again, and we will help you continue to navigate what can be a really challenging process. I'm a licensed attorney. I focus in this. This is the area of my practice. I've reviewed probably closer to 2,000 contracts at this point. My goal is to help you make the best decision for you. Sometimes that may mean walking away from a contract. I am never going to advocate for you to sign just because I want that additional, I want you to sign or because I have any incentive in kind of getting that additional yes. I want you to be in the spot that's right for you. So tonight we're going to talk about the basics of contracts. I want you to walk away knowing the right questions to ask. I want you to walk away understanding red flags and how to identify them. I know that that is, something that a lot of doctors ask about. They're questions that I get all the time. So we're going to hopefully help you identify those when you're looking at your own contract. So we're going to talk through the basic components. We're going to then pull out the components that have the biggest potential for problems. And then again, we're going to look at the potential red flags. So we start with basic components of a contract. Now, these are not going to be the exact wording that you see in every single contract. They're not going to be the things that are always in this order. They're not going to be, always called these exact things, but these are the general things that I want to see in a contract that I'm looking at. These are the things that I think need to be there in order to protect you and give you the things that are needed to outline this contract. So what we first start with is how long does the contract last? Just basically the timeline. When does it start? How long does it last? When does it renew? How can I get out of it? How can the employer or the hospital or the practice get out of it? What are the duties for the job? And I know that that may sound really, really basic, right? Because we think, well, I know what the job is. I'm going to work full-time outpatient. Okay, great. What does full-time mean? Okay, it's 40 hours a week. Great. How many of those hours are patient facing? How many of the hours are protected admin time? Do you have to work 5 days a week or can you work 4 days a week? Are those days all weekdays or are there some weekend expectations? Do you have any late clinic expectations, any early expectations? All of those things I see in contracts, particularly in primary care. So we want to know what is there. We want to know if you're taking call. Now, this is something in primary care that we don't see as much of. There may be some clinic call. There's typically not emergency call, but still we want to know the expectations. Or if you're supervising, right? We want to know what that looks like. We want to know what you are expected to do. When we talk about work-life balance, which I'm seeing here is something that a lot of you do have concerns with, we want to be sure that we have a really good understanding of what the expectations for you are, and we'll talk more about that later. It is the contract needs to tell us what you're going to be paid, how much you're going to be paid for particular tasks. Is it based on the achievement of particular metrics? Are there opportunities to make more? Is your compensation guaranteed? Are there additional recruitment incentives? Meaning, is there a signing bonus? Is there additional money that will be available to you for student loan support? All of those things we see. We want to be sure that you are maximizing those opportunities. So we want them to be laid out. There are times that I will see contracts that don't mention any of these things at all. And then the doctor will tell me, well, they said they'd give me a signing bonus, but they just can't put it in the contract. That is something I want to dig into a little bit more. Now, maybe it won't be in that document. Maybe we're going to get it in another document. That's fine. It needs to be somewhere, right? We want it written down. Um, you may see a situation where you're signing to go work for a private practice and you actually have a hospital in the area who's going to be the one um, signing a contract with you that says, hey, we're going to give you the signing bonus. That happens too, but you want those things documented. Additionally, we want the contract to tell us if you're getting benefits. Now, if you're going to be an independent contractor, we don't anticipate that you will. Still, the contract should tell us that. We want to know when the benefits will start. I see contracts that they'll start on the first of the month after you've been here 60 days, or they start 90 days in, or you vest, in the 401k at year four, right? There are all of these various timelines. We want to know all of those. We want to know PTO, CME support, things like that. Often, the language that you're going to see around benefits is you will have the same benefits as similarly situated employees. And that means you'll get what everybody else gets. The other family medicine doctors get X, you'll get X too. Generally speaking, that seems fair. If you're going to go work for an academic institution, a large hospital, a large health system, those benefits are probably going to be robust. They're probably going to be um, a pretty good offering. So I don't have really a concern with that. However, I was reviewing a contract a few weeks ago, and that's the language that we saw. And the doctor was going to a small private practice. So I said, hey, let's get some more information here. Let's ask, what does everybody else have? And when we did that, what we found out was that yes, the contract said the doctor would have what everybody else had. Everybody else had nothing. So the contract said if benefits were offered, she would get them. Benefits were not offered. So whatever the contract says, we may need to do a little bit more digging, but we definitely want to know what's there. And then sort of part of that, we want to understand who's going to pay for malpractice, who's going to pay for tail coverage. We want these things to be specifically stated. Um, I am not a stickler about does it have to be a claims made policy versus an occurrence based policy. Um, I want them to pay for both. I want them to pay for I want to do that. I'm fine with it. Again, ideally, they're going to pay. That is what matters. Um, but we want it specified. Now, something else that you're going to see, if you Google doctor employment contracts, indemnification is something that's going to come up a lot. So I will kind of give you a quick, law school in 60 seconds um, explanation. Indemnification means that you don't hold me responsible for your actions and I don't hold you responsible for mine, which of course on its face seems really fair. But when two entities are working together, it can be difficult to sort of untangle who did what, right? So sometimes you'll see if your hospital are sued because of my actions, I, the doctor, will be responsible for those. Um, which means if they are made a party to a malpractice lawsuit that you were part of or was based on your work, you're going to bear the financial responsibilities of that. Um, I think that goes too far. What I want to see is a more limited indemnification clause. Let's say that the clause says, hey, I will indemnify you, meaning I won't hold you responsible for any intentionally or grossly negligent or criminal act. If I break the law, if I falsely bill, things like that, that's on me. I think that's fine. To say anything I do, you're not going to be responsible, um, I think is overly broad and puts you at risk. And then the financial penalties. And what I mean there is, there are times where we'll see in a contract, hey, if you breach, you're going to have to pay damages, or if you terminate, you're going to have to repay credentialing fees or things like that. So I think I saw a question. Let me see if I can get to that. Um, I thought, sorry about that. Okay. So the next section is one that I think a lot of people hear a lot about and see a lot about, of course, and that's restrictive covenants. So we're going to start with kind of the the least exciting, I guess, and that is exclusivity. So this is one that exists during the term. And what that means is that it's going to apply while you're there, while your contract is active. And it's going to say something like, hey, while you work here, if you go work somewhere else, you need to get our permission. And it may say, while you work here, you can't do anything if it conflicts, or you can't do anything if it's during our scheduled time. It may say you can't do it at all. It may say, again, you need permission to do it. That matters to varying degrees, right? Some doctors really, if you're going into a hospitalist role or urgent care, um, where there is just sort of naturally some chunks of time where you're going to be available, maybe that matters to you a lot more. So understand what that's going to look like and understand the difference between an exclusivity clause and a non-compete clause, which we'll talk about momentarily. Now, a non-solicitation is a covenant that's going to say, hey, while you're here and when you leave, you can't try to get people to end their relationship with us, right? You can't take people away from um, what what you are, uh, what their relationship here is. So that may apply to patients, right? You can't try to take patients away. You can't try to take employees away. So there are varying degrees of that. Again, it may say, hey, you can't actively try to take them. Okay, fine. Um, if it says, hey, you can't treat that patient, that's where I have a concern because that starts to infringe on the patient rights. So we want to understand, again, the degrees of that and what you're comfortable with versus what you're not. And I saw a question. I am still on this same slide. We're still kind of talking through the contract basics and what we see here. So the non-compete um, is the other restrictive covenant that we see a lot of. And of course, that's one that, again, I think a lot of people understand. So it has components. We're going to see the geographic component as well as the time component. So it will look something like while you're here and for a year after you leave, you can't practice within 10 miles of the clinic. Um, you want to understand, first of all, what's allowed in the state that you're in. Every state is going to have different rules. Some don't allow non-competes at all. Some don't allow them for medical professionals. Some limit them for medical professionals. Some limit them for certain specialties. So it is certainly something to be mindful of. Some are going to say, hey, you can't compete for a doctor that is more than 5 miles. Um, all of those things exist. At the federal level, there is not regulation on how these can be enforced. That was something that was tried. It didn't really go anywhere. We've seen some indication that there might be some interest in trying that again, but No real movement on that at this point. So that's the first piece. Um, in my experience, where I think you're going to have the most luck is not in getting it tossed out, is not going to be even necessarily in the time frame or anything like that. My experience is that where you're going to have the most luck is in getting the type of work narrowed down. So if you are going to be practicing in a traditional outpatient, uh, family medicine practice that's owned by a hospital system, then maybe what we can do is say you're not going to practice outpatient family medicine within, however many miles, but you can go work at a VA. You can go work at an FQHC. You can go work at an academic institution. You can go work at a critical access hospital. You can go work in a federally underserved area. Um, right? Any place where we can distinguish, hey, this thing that I would do is different from what I'm going to do for you. You could go work as a hospitalist. You could go work in urgent care. Maybe you could go work in um, emergency care. All of those things are going to, of course, be distinguished from that traditional outpatient practice. And of course, it would work in the other directions as well. So that's really where like I said, I've seen the most success is when you can come in and say, hey, I completely respect your non-compete, even if you don't. I completely respect your non-compete. These things aren't going to be competitive. So can we get an understanding here? So that's my best advice and something that I advise doctors to do. And like I said, have seen some luck. So out of those, um, okay, where's the biggest risk, right? Where is the biggest potential problem? Certainly compensation. We see a lot of questions about compensation, a lot of discretion, a lot of doctors who are into a contract and they get there and realize, okay, I didn't understand the compensation and now things have not worked out the way I thought they would. Um, Doctors who want to understand their exit strategy, they want to understand the risk that comes with that. And then again, well-defined duties, understanding what the job looks like, understanding what success within the job looks like, are all things that we want to understand going into an agreement with compensation. Again, this is where we're going to spend kind of the most of our time this evening. So we see Dr. Jones has signed a contract. He is getting paid $250,000. He's really happy. And then starting in year two, his comp has gone down. He's not really happy. He has no idea why this has happened. So, what's the problem? He doesn't know what his compensation structure is. Um, he may have relied on what he had heard. He definitely didn't know, the right questions to ask, or if he did know the right questions, he didn't ask them. And he didn't know how to approach the subject likely. So when we're looking at compensation structures, in my experience, they're one of these four categories. Now, there may be hybrids and there may be um, circumstances that are a bit more complex, but typically this is going to be where they are. So the first is a guarantee, and this is going to be just what it sounds like, a flat rate, not based on any particular metrics, but this is what you'll make. Often this is only going to be offered for a certain amount of time. So maybe a year, maybe 2 years, maybe 6 months. Um, you may also see a guarantee plus production. That's probably more common. And that's where you have a flat salary with the potential to earn more based on um, some type of productivity. Now, that could be maybe a quality bonus, even. Typically, it's going to be patient encounters, collections, panel size, WRVUs. Those things are what we're going to look at. Um, how we measure productivity is really going to be based on what type of practice you're in. So, patient encounters, panel size, those are going to be concierge practice, capitated models, FQHCs. That's where we're going to see that. Those things matter. Private look at collections. Um, Hospitals, health systems, academics are going to look at WRVUs. So that's where those things will typically come into play. Now, again, there are always exceptions, but that's kind of the general rule of thumb. Um, for WRVUs, and I'm sure that most of you know this, but WRVUs um, are the numeric value that are assigned to CPT codes. So you see a patient, you document that documentation, it's assigned a CPT code, and then the CPT code is given a numeric value, and that is the WRVU. So they want one thousand RVU. You will pay 50 RVU. Oh, in that scenario, you've got three different numbers to play with, essentially. So you're going to that salary, your base, or hi, I am so sorry about that. Can everybody see and hear me? Okay. Um, Thank you very much for letting me know. So collections, I think, is where we were talking. So you're going to have a base salary. You're going to have a threshold that says once your collections reach this number, you're going to get a percentage. So again, you've got three numbers. You have that. Um, You have that. I am so sorry. I don't know what's happening. I hope that everybody is able to see me here. Um, is Can somebody give me a thumbs up if you're able to see me? I see that somebody said I it's frozen here. Okay. Okay. Good. Thank you all. Um you're still going to have those three numbers that you can potentially negotiate with. And so we want to make sure that they're all working together, that the math makes sense, and that they're all reasonable. If you have a really, really, really great, you're getting 45% of your collections, but the threshold is outrageous, right? You don't get that until you hit $1 million. Well, then it doesn't really matter how great the percentage is, because the threshold is so far off that the whole structure is out of whack. So we want to be sure that all of those numbers really make sense together. Now, the next thing that we see is production only. And that's where we take that base out and you're just looking at productivity. This is kind of what you traditionally would know as an eat what you kill model. So you're only being paid for what you're doing. Now, typically, you're not going to start somewhere based on this model. Certainly not as a brand new doctor. There are always exceptions. You're going to see this a lot in independent practices, private practices, in 1099 positions. Um, there is certainly a lot more risk built into this type of model, there can potentially be reward there too. It really, is sort of a matter of what works for each individual. Um, Time-based is the one that's kind of the outlier here. Obviously, the others sort of build on each other. Time-based is something that we're going to see in particular um, practice settings more often, and it's just what it sounds like. It's going to be based on particular hours or shifts. So you may be paid, you know, $1,800 a shift or $160 an hour or something like that. Now, you may see that as a hospitalist or in urgent care. Now, it may also be that you're working in a clinic and you're paid guarantee plus production, but then you're doing some work as the quality director, and that's going to be paid time based. Or you're working with the GME program and that's time based, right? So you may have components um, of both, or of multiple within the contract. It's also possible that you may shift, right? That you may start um, with a guarantee plus production and move to a production only. So understand that if you see, you start reading the structure and it says your compensation is guaranteed, don't stop reading, right? Keep going with that because the structure certainly may change over the life of the contract. So again, this is looking at clinical compensation. There are going to often be other opportunities um, for compensation. So you want to know what that potentially will look like. Can you earn money for, um, again, for GME work, for medical director work, things like that. So be sure that you're maximizing those as well. So we've talked now about, okay, um, we've assessed our compensation. We know kind of where it falls. Now, what do we do? A lot of employers are going to look to external surveys that give them a good benchmark. So we're going to talk about the one that I think is used most frequently, and that is the MGMA data or the Medical Group Management Association. It is a large survey that's put out every year. Their report, the survey report is put out every year. So that will actually come out in May of this year, the new data. Um, it is a wealth of information each year, but like any other data set, and I know I'm talking to scientists here, and I am very much not one, so you understand this better than I do. Um, like any set of data, it is imperfect. And there are things that you need to understand in looking at the data um, in order to interpret it. So the first is the number that you're going to most often see is the total compensation. So if somebody says, hey, what's the MGMA for family medicine in the South? The number that's going to most frequently be told to you is that total comp number. That number is all cash compensation that's paid to the doctor. Salary, bonus, incentives, call pay, GME stipend, all of that. It does not include the valuation of benefits. It does not include retirement contributions on the part of the employer. That's important to note because sometimes the employer is going to say, this is a total package of $415,000. And when you look at their worksheet, they will have included the valuation of benefits. Those benefits have value, but they are not included in the MGMA definition. So if they are trying to tell you, well, hey, we've met the median because, here are our numbers, but they've included that data, they have not. Now, it also includes the RVU threshold, the conversion factor, the collection, all of those things that we talked about previously. You're going to find those data points within the report. Um, you can also, of course, filter that. You can look at population size and practice type and your level of experience. You can look at who owns the practice, those types of things. The filter that is most typically used is regional data. So we're going to divide the country into 4 regions, and that's what's most commonly applied. Certainly look at um, the data that's relevant for you. I will tell you, though, that employers are not allowed to cherry pick, as the government calls it. So they cannot say, hey, for this doctor, for this position, we're going to use these 7 filters because that gets us the number that we want. And then for this position, we're going to use 8 completely different filters because that gets us the number that we want. They have to apply the filters pretty evenly. So understand that they may not apply, if you really try to drill down too far, they may not apply those same filters. Now, there are some limitations here, again, just like with any data. They don't know the specifics. They're not going to tell you how long, or they're not going to account for how long a position has been open, how hard they've been recruiting, um, how badly an area needs a primary care doctor. They're not going to account for the fact that you're bringing something to the table that they have not had. And the other assumption that they make is that everybody is full time and that everyone defines full time the same way, which when we go back to our discussion of scheduling earlier, we don't, right? So for some people, it may be 40 patient facing hours. Some people, it may be 32. Some people, it may be 312. Some people, it may be 5/8. Right? Some people, it includes call. Some people, it's not going to include call. Some people may get 3 weeks of vacation, and some people may get 8 weeks of vacation. So the data is relevant and the data matters. There are some imperfections in it. So when you've got 2 contracts in front of you and the numbers are the exact same, um, look for the places where they're different, right? Make sure that they are in fact the exact same. Just because the numbers are doesn't mean um, that the whole package is. So what what is an example of what we get in the data? So this is just a snapshot. These numbers are not meant to tell you, hey, this is what you should be paid. These are national numbers, so we don't have region specific. But this is what the numbers have done over the last 4 years for total comp in family medicine. This is fairly typical um, to see just a really steady, healthy growth. Sometimes you'll see bigger jumps, sometimes you'll see um, hardly any at all. Occasionally you'll see a dip. And this is across all specialties. But here, we have, again, kind of what has been fairly consistent. Um, this is looking at compensation based on the number of years in practice. So I think that this is really interesting because we see this in a few specialties where we kind of have a little bit at 8 to 12, but that's pretty close. But we kind of have that, steady climb and then it dips down. And I think, there are a lot of doctors who, toward the end of their career, they start to pull back a little bit. And so that compensation does go down a hair, right? They're still there, but maybe they're not, they're only working, 30 hours instead of um, 36 or whatever that case may be. But again, this is sort of over the lifetime of a career. And then these are numbers based on a physician coming out of training. So that guaranteed compensation we're seeing is 240, a signing bonus of 25,000 with relocation of 17,500. So again, all of this data is provided in the MGMA. It is something that we look at with doctors when we review contracts. It's not meant to be prescriptive. It's not meant to say this is exactly what you should get, but it's certainly a good tool for you to use and a good tool for you to know how to interpret and understand. So the question that I get often is like, okay, so do I ask for more? I think that there are a lot of better questions, a lot of questions that help us understand the structure better. Is my compensation guaranteed? Um, if it's not, maybe that's the best ask. Maybe extending the compensation guarantee, right? If it's only for 6 months, let's get it for 1 year or 2 years. Um, when is the structure going to change? How often has it changed? How often has it been renewed? Is everybody paid based on the same structure? It's not the same as asking, is everybody paid the same amount, but does everyone have the same opportunity? If there's a quality component, how are those determined? How are those awarded? So understanding all of that is very important. How often, again, are we looking at that structure? How often is that being assessed? If you are doing call, is that compensated? Certainly, that can be an opportunity to make additional money. If you do more, do you get more? If you're supervising APPs, if you're working with residents or students, are those opportunities going to lead to more compensation? When are bonuses paid? You may not be able to change this, but no, because you don't want to leave money on the table. Very often, you're going to see that quality bonuses will be paid annually. And the quality bonus for 2025 may not, it may be being paid right about now. And your contract may say that unless you're employed when it's paid, you don't get it. Meaning somebody could have worked for an organization for all of 2025. And if they left yesterday and that check came today, they didn't get any of it. So understand the timing of those bonuses. Um, Again, even if they won't change it for you, um, just understand your own timing. When do you get more? Are there opportunities for growth over the next few years? And then are you leaving recruitment incentives on the table? Can you get more for student loans? Can you get a bigger signing bonus? Make sure that you're maximizing those things. So I know we have spent a lot of time on compensation, but again, I do know that that's something that a lot of you have questions about, and that's just, a significant area. So we're going to talk about risks. We're not going to spend near as much time there as on compensation. So we have Dr. Singh who was employed where she trained. She's now ready to move on. She's not really sure what to say. So she needs to understand her exit strategy. And my best recommendation is that the time to negotiate exit strategy is before you sign the contract. You want to understand what those options look like. You want to understand if there are penalties, and you want to know, um, how you're going to be able to get out of the contract. Um, there are going to be a couple of options available to you. 99%, that's, I, I don't know that that's scientific, but most of the terminations that you'll see are going to be without cause terminations. If you are in a situation where you think you have grounds to terminate without cause, or if you are being terminated, I'm sorry, if you have grounds to terminate for cause, or you think you are being terminated for cause, I would suggest contacting an attorney. That can be a really significant issue. So we're not going to dive any further into that one, but I will just say, certainly, that's one we don't see often, and that's one that should be taken seriously. Without cause means I'm just ready to move on. Now, it may mean I don't really like these people. It may mean that, frankly, on their part, they don't like you. And that's unpleasant. Nobody likes that, but, it could be. It may mean that they're not who you expected, right? So it's not that everything is just perfect, but it means that nobody breached the contract. Now, it could also mean, hey, I'm just ready to be done. My partner is out of training and we're going to move, right? It could be any of those things. you're usually going to see a time component, and 90 days is the most common. That is what I recommend. You want these to be mutual timeframes. So you want to see the employer and the employee giving and getting the same number. I've seen contracts that say the employer is going to give 10 days and the employee is going to give 180 days. Well, obviously, that's problematic. So we want, again, my ideal would be everybody gives 90 days. So we've determined, okay, this is how we get out of the contract. So now what do we want to know? Um, of course, we want to know who's going to pay for tail coverage. Um, we want to understand, how is that going to be covered? Who's going to pay for it? If we can't get it negotiated in that this employer will pay for it, then let's see if we can get the next employer to include that in a bonus amount. As I've talked about, we want to be sure that we understand the non-compete. I've told you kind of my best tip. If we can, get some negotiation there, understand your state laws, and then understand any financial penalties. Um, as I've said, I've seen contracts that say if you terminate within the first 2 years, you're going to pay back all of the recruitment incentives, you're going to pay back credentialing fees, and you're going to pay damages of $50,000, right? Something like that. So you want to know what all of that looks like. Typically, those recruitment incentives do come with a time commitment. So you want to get all of that very, very clear going into the contract. So you know exactly what that's going to look like um, at whatever point you leave. So the last part of this section that we'll talk about are the expectations of both parties. So we have Dr. Wynn here who joined a group. Everybody had Fridays off. You can tell she's very happy about that. And then here, she gets her schedule and she's working on Friday. So she is much less happy. The problem here is that she made some assumptions. She didn't ask questions. She didn't ask for specifics. And again, she may have relied on what she had seen or heard and not gotten those details. So these are part of the expectation conversation that I would encourage you to have. I don't expect volume to be in the contract, with this exception. If your productivity is going to be based on patient panel, on the number of visits, number of encounters, then of course it would. Sometimes with hospitalist contracts, you'll see that, hey, if you're seeing more than 17 patients a day, you'll get a bonus. Those are pretty much the only circumstances where I see volume written into a contract. Otherwise, it's just good to have that, understanding with them. How many do you expect me to see a day? And if they tell you a number, the next question that I would have is, at what point do you expect me to get there? Because we know you're not going to be there day one. So how much runway are they giving you? But we do want schedule and location to be addressed. As I've said, okay, you're going to be full time. What does that mean for them? Um, how much flexibility do you have? Who's determining the contract? Often the contract is, or who's determining the schedule? Often the contract is going to say the employee is going to work when the employer tells them to. So if they tell you, hey, you're our new Saturday and Sunday person, you can't do anything about that unless the contract protects you. I'm not telling you not to trust them. I'm not telling you that it will say that. I'm just saying understand what's in your contract. The same with locations. Um, Sometimes you will see a posting for a particular location. You will go to a location, you will tour a location, and then you'll get your contract and it will say you will work at any of our locations that we assign. Now, that may just be generic language, but understand that. Understand that if they decide, hey, this location isn't really working out, or we are just going to have this location be all APPs, we're going to move you across town. They can do that. I would love for schedule and location to say that they are based on mutual agreement, to say that they um, can't unilaterally make a decision without you coming to the table. Um, and again, we want to understand call. Again, this is something that I usually don't see being as significant an issue in primary care, but it certainly still can be. So understand what the maximums are, what the minimums are, how that's going to be divided. These are questions that I would ask about expectations. These are questions that I would use as ways to start conversations about what success would look like. These are not questions that I anticipate in any way, shape, or form being in the contract. So, things to understand about them, things to get to know about them, not anything to have clearly, documented. So the last thing we're going to talk through are red flags. And I know that everybody really wishes that I was about to hold up a sign or have a slide up here with, 3 bullet points, and these are the words that you can't ever have in a contract. Unfortunately, that's not what I have. Because just like we've talked about, certain things are going to be okay in a contract for one person and not for another. Um, if you're going to go practice in your hometown and you never, ever, ever, ever want to leave, then a non-compete is going to be a real problem for you. Um, if you tell me I want to maximize compensation, I want to work as much as I possibly can, then an exclusivity may be an issue, right? So there are certain things that mean something to certain people. So it's really difficult to say, hey, this particular clause is a deal breaker, walk away. So to me, the deal breaker is a lack of transparency. That's the red flag. When you ask questions about a really, really um, non-detailed contract and they just won't give you any more. When the contract leaves all the power with the employer, they will make all the decisions. Um, they will tell you when to work, where to work. I've seen contracts that say in year one, we're going to pay you, this particular amount. And then in year two, we'll pay you something um, reasonable at our discretion. I, no, I mean that left me truly speechless. That's something that I would be very, very, very cautious about moving forward with. You also want to be cautious about how much risk you're taking on. If you are paying for malpractice, you're paying for tail coverage, you have a huge non-compete, you can't get out of the contract for 5 years. Um, all of those things are on you. Again, maybe there is some scenario that makes that okay, but I would be very thoughtful about it. So balancing risk, making sure that you have information that you need, all of those things matter. All of those things potentially can be red flags, but for me, the biggest is a lack of transparency, is when they really won't come to the table. So that is again, I know that a lot of people wish that I had kind of a magic word here, but um, everybody's red flag is going to be a little bit different, but this is the one that I think is kind of the overarching. So we've talked about compensation structures. We've talked about how to assess the risk and the penalties around the exit strategy. And we've talked about how to make sure your contract talks about success, talks about the framework in which you're going to do this job. So I really appreciate the time. I appreciate you all being here and spending part of your evening with us. There is a code here on the screen. It is FM Comp 20. And if you enter that when you sign up on our website, you can get 20% off of our contract review services as our thank you for um, being here this evening. There's also my email address in our website here. We offer free consultation calls to answer questions about our process, about kind of how we work, and um, like I said, what our process is and what we do. Um, all of that information is also here in the chat. If you have any questions, I know I have one here and I'm about to answer that. So if you have any questions, um, I'm happy to answer those here. You can also reach out to me directly. So I've got a couple. I will um, start to answer those. So the question that I have is or COLA or cost of living increases typically included in contracts? No, is the sad answer. I don't typically see those. It is pretty rare. Um, if it is an FQHC or, a like quasi-governmental entity that is the employer, then it may be, but otherwise typically not. So, something that you would just need to come back and renegotiate in a couple of years and kind of maintain awareness of. Um, the next question, and I think you all can see this, is about tail coverage and um, kind of being tiered over a number of years. So for tail coverage to be provided, I see the the full gamut. I see situations where they don't pay anything. I see where they pay everything, and I see all points in between. Um, Academics almost always pays for everything. Private practices typically don't pay for much, if anything. And that tiered structure is actually pretty common. So often it may be 3 to 5 years. I would say five is probably more typical. 20 year or 20% based on a year. So for each year you work there, they'll pay for 20% of tail. After 5 years, they pay the whole thing. Um, you will often see that they'll pay for it based on the number, or I mean, based on the reason that the contract ended. So if they are the reason, they terminate the contract, they'll pay. But if you terminate, you have to pay. And sometimes it's a hybrid, right? If it's in year one and you terminate, it's something like that. Um, so that is fairly common to see. Um, I, I don't think it is completely unfair. I mean, I understand them wanting a time commitment because it is a financial commitment on their part. If you know it is not a long-term position for you, I would certainly try to negotiate that to as short a time frame as possible. But yeah, not unusual to see that at all. Any additional questions? Um, the turnaround time for our reviews, typically that's about 3 business days. That is certainly not a guarantee, but that's usually what it is. So if you were to sign up today, you know, end of the week would be what that would normally look like. We have a lot of flexibility in kind of what that scheduling looks like. So what I always tell doctors is, if you go into the sign up process and you don't see a time that works for you, reach out to me directly. Um, Most frequently, I'm going to be able to work with you and kind of make that, you know, figure something out. So just let me know um, on that. But certainly, we like to be flexible and we know that timing on these things matters, so we try to get it done pretty quickly. How easy is it to negotiate with larger companies? Boilerplate contracts. So that certainly does happen. I mean, boilerplates are certainly um, something that we see. A lot of places are going to say that. I would say there are still going to be some things that they're going to be that you're going to be able to move the needle on. There are only a couple of large employers across the country that I can think of that truly I've never seen make one, change one apostrophe in a contract. Most of the time, you may be able to get something done. Now, that doesn't mean they're going to change, you know, they're going to completely rewrite their non-compete or they're going to upend their, you know, termination section. There are times, like I said, when they're going to hold on pretty tightly to certain pieces of it, but you may be able to get, that signing bonus, or you may be able to change some of the repayment terms, or, um, some of the other things that we talked about here. So, um, how easy is it? It sort of depends. Now, what I would say with those larger companies, the good news is, even where they're not willing to negotiate, they probably are going to be able to give you some good information. Where smaller companies, if you ask for, hey, do you have a policy about X? Can you give me, the last 10 years of, um, what quality payments have looked like? They're probably not going to be able to put their hands on those as quickly as the larger corporation. So again, those one of the companies that I talked about that I've seen never change anything, they are great about providing as much documentation, as much policy as um, you want to see. So, you know, I would say there are still questions worth asking. Anybody else? Well, again, my email address is here and in the chat. So if other questions come up, or if there are things that you'd rather reach out kind of one-on-one to talk about, please feel free to do so. You can again schedule some time or email me directly. But I would love to talk with talk with you more. Certainly save our promo code and feel free to use that um, when you need it. And I appreciate you spending part of your Monday with us, and I hope you enjoy the rest of your week. Thank you so much.